Good morning, everybody. I'm Xavier Wittebole from the Saint-Luc University Hospital in Brussels, Belgium. I thank Professor Vincent and the organizer for inviting me to give this talk on the current status on phage in this session on infection. I have no particular conflict of interest to declare regarding this lecture. And so some words of introduction. So we know that phage are small viruses able at killing and replicating bacteria without affecting any other cell lines. They are certainly the most abundant and ubiquitous organism on Earth. Uh, the history of the discovery of phage started actually about more than 1 century ago, since it was the end of the 19th century when it was described, the phenomenon of phage was described in India. But certainly the two major names in the discovery are Frederick Trott from the UK and Félix Zerel, a French-Canadian scientist who was the first to propose phage as a treatment for infection. We know all phage are able at killing bacteria. They fix their tail on specific receptor on the cell wall of the bacteria, inject their genome within the bacteria, and then later on use the cell machinery to produce new phage protein, assemble themselves, and then lyse the bacteria and release a lot of phage again in the media. So what about the clinical application? It is proposed as a preventive medicine to prevent infectious disease. It is also proposed as a curative medicine, and this is probably the most important since we know the threat of multi-drug resistant bacteria and the evolution of the multi-drug resistant bacteria within the community at the present time. And of course, we could also use phage proteins, but this is out of the scope of this talk. It will depend, of course, the clinical application will depend, of course, on the place where you live, the place where you work, the medical specialty you have, the unit where you work, etc. So very different topics according to what you're doing in medicine. So is it effective? This is really the topic of this talk. Is it effective? Well, we could have a look at randomized controlled trials. We will also have a brief look at some case series and then, of course, many case reports. Randomized control trial, well, it all started in the former USSR republics. And we have a study published already 85 years ago when they used phage therapy against dysentery. The results of the study were concluded as positive since there were 86% in patients with mild symptoms or 50% in patients with severe symptoms, but it was at day 3. And when we have a close look at later results, well, it didn't look that phage did as well as a standard of care. A second study, a larger study that was performed during World War II and the Finnish campaign from the USSR against Finland. And they used phage at that time to prevent the development of gangrene in soldiers coming back from the battlefield. And they again proposed some positive result with less gangrene developed in soldiers treated with phage as compared to standard of care from those wounded soldiers. A very large trial published in the late 60s involved more than 30,000 children, and they used phage against Shigella to prevent dysentery. And the way they performed the study is very funny, as one side of the streets, kids were receiving phage solution, and on the other side of the streets, the kids didn't receive the phage solution. And they showed a 3.8-fold higher dysentery in the placebo group. So in summary, the Russian experience displays some very large randomized controlled trials with several hundreds and up to 30,000 patients in a trial. And as a prophylactic treatment, it seems that phage were positive to prevent gangrene and dysentery. So let's go now to what we could say the Western world. A first randomized trial, again published in the late 60s, in 44 children, phage directed against Staph aureus were proposed in children with infective asthma. I don't know exactly what they meant with this entity, but that's the study. And unfortunately, the study was not really positive. Of course, there was a significant decrease in wheezing days, but all the other clinical outcomes were not positive. Another study published in the early 70s, only 8 patients, and the Phages were directed against Vibrio cholerae. Well, Phages did good because with the higher concentration, it's certainly better than no treatment. However, Phages did not better than tetracycline as a treatment for this entity. Then we have to wait until the new century, and the first study published was from Texas, when they used Phage in a 42 patient with chronic venous leg ulcer. This was a phase 1 study, and the Phage were directed against E. coli, Staph aureus, and Pseudomonas. There were no prior sensitivity study, and the Phage treatment did not really show any improvement. However, there were no adverse reaction, which is quite constant. Whatever the study you're looking at, it doesn't seem to have adverse reaction with Phage treatment. Another study published on the same year in a patient with chronic Pseudomonas-related otitis. There was some improvement in the subjective symptoms and clinical exam, and also a decrease in the burden of Pseudomonas in this 24 patients treated. Another study from the Nestlé company, but performed in Bangladesh, using Phage in in kids suffering from severe diarrhea. Oral coliphage showed a safe gut transit in children, but failed to achieve intestinal amplification and to improve diarrhea outcome. So the authors conclude that certainly more knowledge is required before going further. Another study from the same group in the same country, in Bangladesh, randomized study on the potential of Phage to eradicate Staph aureus scourge. 21 women, actually we have only safety data, no efficacy data, which is something really missing from that study, published last year in 2019. And then, of course, we have what we have expected to be a large randomized controlled trial on the use of Phage in burn wound infected patients. So a patient admitted in burn units. This study was developed by the European Research and Development Project, and the European Commission funded this trial. It was performed in 3 European countries, Switzerland, France, and Belgium, in 5 burn units, and only 27 burn patients enrolled, with 25 patients included in the modified intention to treat analysis. The 2 groups were not really similar when we have a close look at the details, and unfortunately, Phage did not help to reduce the time of bacterial burden in the most infected wound or in all wounds. So you can see here the Phage treatment and the rapidity for the standard of care treatment. So the conclusion was unfortunately not that good, since the Phage solution decreased the bacterial burden in burn wounds at a slower pace than standard of care. However, what is important to understand this negative result is that actually the Phage concentration was certainly lower than the expected concentration, and so it seems that there is some issue with the way we can preserve Phage within the solution. Another study, a randomized controlled trial coming from Australia, a prospective open label in only 9 patients suffering from chronic rhinosinusitis, previously treated, and the solution at various concentration. Well, it seems that the highest concentration did help a little bit, but not that much. So in summary, the randomized controlled trial performed in the Western world, where we can see that the research remained very limited by the number of studies and by the number of patients included. The result looks disappointing. The only point which is really positive is that actually there is certainly no adverse event with the Phage solution. Then we can have a look at some trials or some case series, and here is one from Poland already published a few years ago. More than 150 patients, various sites of infection, various bacteria, and the treatment looked also disappointing since we have 60% of the patient not really responding. However, it means we have 40% of patients responding, and those patients responding with phage therapy actually did not respond with previous antibiotics treatment. So maybe some interest with phage. And then we have many case reports. And one of them is one we had in our institution when we treated a 40-month-old child from Northern Africa who was admitted in the hospital to undergo liver transplant because of biliary atresia. She had multiple liver abscess with multi-drug resistant Pseudomonas. Pseudomonas was, the phage solution was injected within the abscess, was injected intravenously, and during the transplant procedure, the phage solution was used to rinse the abdominal cavity. The evolution was, of course, very good, but the problem is that all those patients treated in reporting case report, of course, are usually positive cases. And of course, we will probably not publish a case where we failed to use phage therapy. There are many ongoing projects. You can see here a study which is currently performed in Georgia, so a former USSR republic, on urinary tract infection. And then in the United States, we have the University of California in San Diego, who combine their efforts with the Amplify Bioscience Corporation to perform a trial on intravenous bacteriophage in 10 patients with resistant, so MRSA infected ventricular cyst device, already treated with antibiotics. So the FDA gave approval to perform this study, which is ongoing. And the same university in the United States launched the Center for Innovative Phage Application and Therapeutics, which is quite the only one in this world, in this part of the world. We have also other countries in France, in Belgium, there are ongoing development programs. We also have other applications for phage, but this is not the scope of this study. And so in summary, we could say that phage looked like an extremely attractive potential treatment to help fighting the infections. And the potential applications are actually as numerous as the number of difficult to treat infections. However, we have to define phage efficacy in well-conducted clinical trial, and we have to be careful not to throw the baby with bathwater. And so maybe we went from bench to the bed, but we should go back to the bench to clearly be sure we will not throw the phage therapy, which looked quite interesting. I thank you for your attention, and I have special thanks for Steve Opel from Rhode Island and Ina Shanishvili from the Georgia Eliava Institute, who conduct phage trial. Thank you very much.